Hello, everyone. We are going to go ahead and get started on this lovely Friday for our next CPC. So we have a case of
COPD.
a 55-year-old male, past medical history of heart failure, COPD, OSA, cocaine use, prostate cancer, coming in for shortness of breath. Dr. Anderson has decided it's going to be a COPD exacerbation, so we'll see. Before we get into it, we're going to have an introduction to Dr. Anderson. So he is an assistant professor in the Department of Pulmonary and Critical Care. Associate professor, excuse me. Did his medical training at the University of Illinois in Peoria for med school, and then came here for residency and continued on for fellowship before joining our faculty. And a 55-year-old guy with heart failure, COPD, OSA, cocaine use, coming in with shortness of breath. So do you have any initial thoughts about what we're working with here other than COPD exacerbation?
Yeah, do we have that slide too?
We do.
Okay. So is that for me to advance?
Sure, yeah.
All right. I don't want to go to the diagnosis yet. All right. So this was the stem, and all of these stems are never very helpful whenever it comes to CPC. So at least whenever I'm interpreting this, from a heart failure perspective, to me, it means more whether they have ischemic disease or non-ischemic disease. So we'll see a lot of patients with sarcoid that have non-ischemic cardiomyopathy for several years that is missed. How bad is it, and whether or not they have recurrent exacerbations as well too. For COPD, is it really COPD, or is it just somebody that has these recurrent admissions and shortness of breath and have been labeled as COPD over the years? Again, how severe is it, and do they have many exacerbations associated with the real diagnosis of COPD? For cocaine, how is this patient using it? Snorting, injecting, smoking. From a pulmonary perspective, all of those kind of cause different pathologies. Is he still using cocaine? Is it contaminated with something potentially that could be contributing? The prostate cancer, again, is this just localized prostate cancer? Is it metastatic everywhere? Potentially increasing the risk for venous thromboembolic disease. And then any therapies that the patient may have been on recently as well too, either conventional chemo or any immunotherapy. And the dyspnea as well too. So how bad is it? How long has it been happening? Any other symptoms? And I don't remember if I have it up here as well too, but what environment it's going to be happening as well too. Yeah, so the location. If I'm in clinic, we always get PFTs on everybody before we see them, do the walk, reviewing the prior imaging. For a patient like this, as the fellow is presenting, I'm going to try my hardest to pay attention, but it's going to be really hard if it's just a middle-aged gentleman with COPD and heart failure. Similarly, if I'm on the consult service or at 11 o'clock at night in the ICU, look at the EKG, make sure they don't have any ischemic disease, and kind of the same type of approach. And again, try my hardest to pay attention. But since this is CPC, my diagnosis that I predict is going to be the usual diagnoses that we see in CPC. So mycosarca, histoamyloid, ICI, G4 disease. So it is likely going to be a combination of these 6 or 7 pathologies. /COPD.
Awesome. Well, thank you for walking us through your thinking initially, and I'll get you some of that information as we go. So we're kind of in between, not in the clinic or the ICU at night, but this is the Barnes emergency room.
Ooh.
So we have this gentleman, he comes in, he's saying he has 1 day of shortness of breath that started yesterday. He was cleaning his house with some cleaning products. They were aerosolized, and that just kind of triggered some worsening shortness of breath. He was using his inhalers, and it really wasn't getting any better. He was unable to walk his typical distance. He was previously able to walk down the street, go upstairs, and he was having more shortness of breath doing these activities. So he decided to come into the emergency room to get evaluated. He does have a cough that's productive, but that's a chronic cough and has been unchanged in the last day since this shortness of breath started. Also have a review of systems for you. He has some chronic diarrhea, congestion. He has this cough, shortness of breath, and wheezing that we talked about. And then he has some chronic back pain that's been ongoing for several years, as well as some chronic bilateral knee pain. And then you mentioned wanting to know a lot more about his past medical conditions. So we'll kind of jump into some more information about that, starting with, most importantly, his COPD. So he has had COPD for a number of years. In the last year or so, he's been having worsening control of his disease. He's actually had 3 exacerbations within the last year, leading to hospitalizations and short courses of steroids. He notices that his symptoms are quite a bit worse when the weather changes. It's actually May right now. And he also notices that his symptoms get worse with irritant exposures. He is on inhaler therapy with triple therapy, and then he also has an albuterol rescue inhaler. And he has some PFTs here. I would love it if you would just kind of walk us through your thoughts about his COPD and kind of the interpretation of his PFTs here.
Yeah, can we just go back a couple of slides first
Sure.
here? Um, so, the only interesting part of this presentation, I think, would be the aerosolized cleaning products. So does he have some type of chemical pneumonitis? Would try to clarify what type of cleaning products that he was using and how it was aerosolized.
I believe it was Febreze.
Is Febreze a cleaning product?
I guess he cleaned and then air freshened.
Okay.
Not sure.
Because if I use Febreze at my house to clean, my wife would say that's probably inadequate to actually.
That is a good
clean.
point.
So
Not
that's just
cleaning.
covering up the dirt.
Valid point.
Yeah. So, patients with underlying obstructive lung disease, COPD, asthma, we're always worried about things like vocal fold dysfunction as well too. So does he just have paroxysmal vocal fold motion and has some exposures that are continuing to trigger that? You mentioned the cough, that hasn't really changed a whole awful lot. You mentioned on his physical exam on the next slide here that I think he was wheezing some. Want to go to the next slide? He was wheezing, and I think I tried to clarify whether or not he's really wheezing from the lungs, if he has both inspiratory and expiratory adventitious sounds suggestive of some type of vocal fold dysfunction as well too. And then the rest of this I don't find overly helpful. The rhinorrhea and congestion stuff with the respiratory illnesses, you could consider or invoke things like vasculitis or some eosinophilic mediated diseases, but I think it's probably premature to try to invoke that. And then the next slide. So for his COPD, for everybody in the room here, our normal PFT presentation here where his FEV1 FVC ratio is less than 70, so he has an obstructive ventilatory defect. FEV1 is 70, which puts him into kind of a mild category. He had a bronchodilator challenge here, which was insignificant. His TLC maybe just a little bit larger than his FVC, and then he has air trapping with his RV that's 143. Then he has a diminished DLCO, but after they adjusted for his alveolar volume and his hemoglobin, it normalized. And I think especially if we're thinking about some other airways pathologies or vocal fold pathologies, always look at the flow volume loops here as well too. His expiratory loop is just consistent with obstructive defect, and the inspiratory loop looks okay here as well. If somebody has PVFM or some fixed obstruction, then you would have either flattening of the inhalation, the exhalation, or both if you have a fixed obstruction up here. So I still don't find this overly helpful, and I'm waiting for something to tell me that this is not just a simple COPD exacerbation.
Sure. And so you were saying he has mild disease based on his PFTs, but he has quite a bit of symptoms and has been presented to the emergency room 3 times this year. How do you kind of correlate the PFT findings with the symptoms the patient is, if at all?
Yeah, you mentioned some kind of respiratory sinus type symptoms as well too. So I think you have to think about, is this an asthma COPD overlap syndrome, which I guess would be more exciting than just simple COPD, but still pretty unimpressive. Thinking about the vasculitis stuff as well too. I'm sure whenever he comes in with his COPD exacerbation, he gets treated with steroids, antibiotics. Will get a little bit better after the steroid administration as well too. Just having this degree of spirometric abnormalities, I wouldn't expect somebody to have this many exacerbations unless there's some other type of insult that's happening or some other environmental exposure. We didn't talk about kind of HP type things, but if he truly has some type of inhalational lung disease related to this cleaning product of Febreze, I guess theoretically that could be contributing as well. And we're just calling it COPD exacerbations when it's really some other type of manifestation or disease process.
Awesome. Thank you. I have a little bit more information about his other medical conditions to give you some information that you had mentioned wanting. So he has just a mildly reduced ejection fraction, has non-ischemic cardiomyopathy that has actually been attributed to his cocaine use. He has a little bit of diastolic dysfunction as well and is on a beta blocker as well as Lasix and lisinopril. He is an active cocaine user. He smokes it and his last use was the day prior to admission. That has been ongoing for many years. He is like on and off been able to quit, but is currently actively using. He is compliant with a CPAP for his OSA, and then he just had local prostate cancer that was treated with radiation therapy a number of years back, which is now in remission. He also has, which I mentioned, some chronic back and knee pain. It got a little worse recently after lifting some boxes, so he's been taking some ibuprofen in addition to his chronic Tylenol and lidocaine patches. Social history, relatively unremarkable, lives alone, no recent travel history, drinks 3 to 4 beers a week, and was a former smoker with a 30-year pack history.
So, I think with the history of the prostate cancer and some increased back pain recently, you worry, has it recurred and does he have some vertebral metastasis and potential fracture? But I think for this presentation seems pretty unlikely. The only extra interesting thing is that he smokes his crack. So we'd want to know, has he actually had crack lung before? Is his dealer still the same? Are they putting anything else in the cocaine or the crack that he's smoking here? And is he having some type of pneumonitis related to these to smoking?
Awesome. He has not had any crack lung before in our system, at least, and denying that. All right, so if you're ready, we'll go ahead and move on to the physical exam.
Perfect.
So he is normotensive and has a normal heart rate. He is a little bit hypoxic, requiring 2 liters of oxygen to get him above 90% on room air. Otherwise, not much new information. He has some diffuse wheezing, no increased work of breathing. He looks pretty comfortable otherwise. He has some just midline paraspinal tenderness of his back to palpation.
And then his baseline oxygen levels are okay. He's not on long-term oxygen and he has enough exposures to the healthcare system that we would have found it.
He had a PFTs with a walk test a number of years ago and didn't require any oxygen at that point, and then has not been on any chronic oxygen since then.
Okay. So hypoxemic, so that's new. The wheezing, I'd ask him, does he always wheeze? It's not surprising in that situation if somebody's a chronic wheezer, whether or not they're still wheezing at this point, but it seems like something else is going on. And then I'd also probably listen over the vocal cords as well too, and see if it's both inspiratory, expiratory, you're worried about stridor or something else as well. And then I'm hoping that we can just ignore the back pain stuff.
We'll see.
As the pulmonary consultant, I would like to say I'm disinterested in your back pain, sir. I recommend you discuss your opioids with your primary doctor.
Yeah.
So hopefully we can pass that. It's not related, but I guess if he's got metastatic disease there and he's got some airway metastasis as well, then it could theoretically be contributing.
Sure. Okay. All right. So nothing really has stuck out so far. How do you want to approach working up this patient, or is there anything you want to do initially?
Yeah, so on my kind of initial slide there, if it's in the ED hospital or emergency department there, EKG, rule out ischemia given his crack is his known non-ischemic cardiomyopathy as well too. Regular type of blood test, so CBC, particularly looking for eosinophilia given his obstructive airways disease, and then just regular kind of CMP, troponin. For an imaging perspective, I think just starting with a regular chest radiograph would be perfectly fine. Given his presentation to the emergency department with these types of problems, he's likely to get a CT scan at some point, but I feel like we have an airways explanation for his decompensation as opposed to a vascular reason.
Sure. Okay. We'll just go ahead and start with some basic labs. He had a CMP that was largely within normal limits, and then a CBC showing just a mild leukocytosis.
Yeah, and cell differential on the white count. You gonna give that to me yet?
Coming soon.
Okay.
All right. And just some other, so I think you kind of mentioned right off the bat wanting to make sure that the EKG looked okay, getting TROPES, BMP. So the BMP was 230s, the troponins were lateral, and there was a normal sinus rhythm on the EKG with no ST segment changes.
I could have interpreted that EKG then. Yeah. A simple pulmonologist could interpret that.
All right. And then I'll let you interpret this one.
All right. So this one is harder just because of the angles. looking from the frontal here, it probably looks okay. There might be a little bit of peribronchial cuffing here. So whether he has a little bit of edema associated with this, or if this is an area of bronchiectasis, I think hard to know for certain. And then down here as well. On the lateral, he probably has a few nodules throughout his lungs here, whether that's just old granulomatous disease in this part of the country, metastatic disease, infection, I think hard to know for sure. So I think comparing to an old film would be helpful. Or as I'm sure I mentioned, he likely will get a CT scan at some point as well.
Sure. And can you point out what like specifically they're looking at on the lateral film that you can't see on the AP?
Yeah, so the benefit of looking at the lateral in these is Tej Patel here. Oh, not time for the Tej talk yet. Tej hates looking at lateral films. So as a sarcoid doctor, I feel like the laterals help quite a bit, mainly because you can find adenopathy hiding in mediastinum here. At least here, I don't see any mediastinal adenopathy, but looking on the lateral, it collimates both lungs. So any extra nodules you see are going to be a little bit more prominent. Whereas over here, we have a couple of small nodules down at the right base. And on this side, we can see a couple of nodules down here, nodule, 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 nodule. So, and they're far enough out to the periphery. All right, Tej, here's your lateral film. I was just saying, you are our lateral chest radiograph expert. And the where these are distributed is far enough out in the lung that it's likely not just normal blood vessels on FOS. So not just turning and looking at you. I think I saw a hand come up back there. Are you a lateral chest film expert as well?
Well, we almost were in the ICU or like when they're kind of like you go to a portable, but like more often than not, when I can, I send them down to the lateral. Like I don't see why would you not like why why not getting more into with the lateral? I don't know. Like I heard those on video about like the lateral film, like maybe like calculated, but like why more info would be better?
Yeah, I feel like the lateral is helpful, but harder to interpret. I feel like looking from the front is a little easy because I'm looking at you, I can kind of anatomically imagine where things are. I know where your heart is, I know where your lungs are, I know where the ribs are. And whenever we're looking at the lateral, since it's collimated, you have to look at both lungs at once. You have to know the lines in the lung and the borders of the mediastinum quite a bit better. But I still find lateral films pretty helpful. Obviously, in an ICU patient, we're not going to send them down for a 2-view chest radiograph. Importantly, for the AP view or the PA view instead of an AP view, you get better aeration in the lung. Typically, the cardiomyocytal silhouette is kind of a more normal size if you're going from the back to the front instead of the front to the back. So I always find PA and laterals more helpful than portables, but has to be in the right patient. Seeing that he got this PA and lateral film in the emergency department also told me that he wasn't that sick, because if you're sick enough, you're not going to send you from TCC back to the chest x-ray to get a 2-view.
Yeah, great. Thank you. All right. And then just some basic.
Is that how they interpreted it as well?
It is.
Okay.
Some just basic infectious evaluation. Everybody coming in, an RVP was negative, and then they ordered a pneumonia PCR, which came back with mixed upper respiratory flora.
Okay.
So sorry, that was not supposed to come up just yet.
Oh, I thought we were going to get the diagnosis right there, but not yet.
And then realizing that the diff wasn't added on right away, the senior, as soon as he hits the floor, kind of adds that on. So you can get a little bit more information here.
Yeah, he went and did a manual count in the lab,
Yep.
right?
Had to run down over to the IOH.
Yep.
Get it himself.
So yeah, there's eosinophilia. So the percent isn't too high, just 6%, but you said the absolute count is 700 here, right? Yeah, so there is some component of eosinophilia as well, whether this is asthma, COPD overlap syndrome, whether he just has COPD with eosinophilia, whether he has some other secondary cause of eosinophilia. I feel like we went through his medications, his bronchodilators, but I don't think we talked about his other medications that he was on at presentation, did he?
He was taking the GDMT, lisinopril, the Lasix, Coreg, and then had been using more NSAIDs recently with the back pain and taking ibuprofen in addition to Tylenol and the lidocaine patches.
Yeah.
Anything from that stand out to you?
Not necessarily. You mentioned acid reflux, I think, in the past as well too. So not taking a lot of PPIs or anything like that.
He has not been, no.
So most of the usual kind of oral outpatient medications, I think, are less likely to cause eosinophilia, but it can happen. And then given his presentation, the possible bronchiectasis on his imaging there, you think about asthma, COPD, and kind of going down the ABPA or allergic bronchopulmonary aspergillosis pathway a little bit there. And then the vasculitis as well too, with the combination of his obstructive airways disease and his sinus pathologies.
And I know a lot of the things that can cause secondary eosinophilia have a lot of overlap in kind of the symptoms that they have. How do you think about the diagnostic approach there and how to work that up?
I asked James. No, so, it was hard a decade ago, I think, whenever we were trying to figure out, the eosinophilic mediated lung diseases, mainly because the treatment was very different, whether you had asthma with severe eosinophilia, whether you had vasculitis, whether you had hypereosinophilic syndrome. And I think now in the era of biologics, since you can directly target the eosinophils, the main difference in making that diagnosis is what dose of the biologic medications you use. As a sarcoid simple prednisone doctor, that's how I approach these things, James. I don't know if you have a more nuanced approach than that, but yeah, so you would love to make a diagnosis of vasculitis that really have it, mainly because the dosing for our anti-IL-5 therapies is like 2 to 3 times as high as the regular asthma doses. But I think, obviously more information for this guy is needed at this point.
For sure. Okay, so what would you want to go to next?
Probably CT scan. That's probably what we're going to be able to get next. At some point, we'll want the rheumatology, serologies, mainly the ANCA, and I guess you can evoke some other autoimmune pathologies as well too, and just having some reactive eosinophilia. Although his eosinophils were 600 or 700, probably not quite to the level where you start thinking about like parasites or other types of fungal infections or paragonomyosis. But if it were a lot higher than that, I guess you could invoke that as well. He didn't seem like a guy that is down south and going on float trips or anything and eating raw crawfish, or
He is not.
a really outdoor type of guy. So it happens.
Sure.
But I think CT scan is probably the next step that I would go down.
Sure.
Is that an option yet?
Yeah, so we can get a CT scan. Your intern is on rounds and is like, okay, we'll order CT chest. What protocol should we get? How do you think through what protocol is most helpful depending on what you're looking for?
So there's 3 benefits of doing a high-res CT at this hospital. Tej knows these already. So the 3 benefits of a high-res CT protocol is, number 1, you get 1 millimeter cuts. So a usual non-con chest CT gives you sequential 3 millimeter cuts. A high-res gives you 3 millimeter cuts and non-sequential 1 millimeter cuts. So it's going to jump or skip a little bit as you're going down. You also get exhalation images as well too as part of the high-res protocol here. So if you're worried about hypersensitivity pneumonitis, if you're worried about like a mix of NSIP and BO, then the exhalation images tells you whether or not there's a lot of air trapping or focal air trapping that can help differentiate that. And then I think the most important aspect of ordering a high-res here is all of those get interpreted by a chest radiologist. Now, Tej is an expert radiologist already, so he doesn't need the chest radiologist to interpret his films. I think most of us in pulmonary are probably okay interpreting them without their help, but it's always nice, I think, to have their involvement. If you're worried more about ILD, vasculitis type things, then I guess you can order a high res. I don't think it's going to add a whole awful lot on top unless we are worried about that more inhalational and possible HP type of pathology. The contrast enhanced scans, just a regular CT chest with contrast if we were worried more about kind of a pleural process, or if you had a lung nodule or a lung mass, that tells you whether or not it enhances. The regular PE protocols don't give you the correct timing to tell you whether or not the lung nodule or mass or pleura enhances with it, but it is better at capturing PE. So for him, I think just a regular non-con CT scan would be okay. But if I'm the one doing the order, I'd probably just do a high res that we can get the exhalation images in coordination with it.
Sure. Okay. So I have some, not these, CT images that will kind of scroll through.
All right.
So it'll loop, but we can
That's fast.
Yeah, we'll slow it down when it comes back through.
All right, so I assume these are the non-sequential 1 millimeter cuts, just seeing that they're jumping as we're going down here. So if you go back just a little bit there, so there's probably some central bronchiectasis here. So I'll tell you when to stop. Go, 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 stop. Back one. All right, so you see this airway here, it's kind of twisted a little bit. So there's some bronchiectasis here in the right hilum. There's a little bit of bronchiectasis down here as well too. Can you go down one slice again? Yeah, and we see there's probably a little bit of that peribronchial thickening here. And then on the left side over here, there's likely a little bit of mucus plugging here as well too. These are the lung windows, obviously. We'll take a look at the mediastinal windows as well to make sure he doesn't have some adenopathy that's contributing or causing some bronchostenosis of any of these areas. Keep going down. I would say the lung parenchyma themselves look pretty good. There may just be a little bit of kind of motion artifact down here at the left, a little nodule, maybe just atelectasis here at the left base. And then motion artifact, and a lot of mucus plugging down here at the left base as well too. So I think in somebody with eosinophilia, the central bronchiectasis stuff, it makes you think a little bit more about asthma, COPD, and possibly ABPA, which is very well described. And whenever I was a fellow, I had a very hard time understanding if they kind of meet most of the criteria for ABPA, but it's not Aspergillus, then we can call that ABPM. And as part of that pathway, then they still have a very elevated, usually eosinophil count, usually very elevated IgE, but then the sequential titers specifically for Aspergillus fumigatus of the IgG and IgE may not be elevated. So they can still be colonized with some type of fungus and have an allergic reaction to that. It may just not be Aspergillus. It could be another fungus instead.
Yeah, awesome. Thank you. This is the only sequence I pulled, but
Oh.
there.
The mediastinal window's okay. Exhalation images didn't show anything. No PE.
Yeah, and there was just some old granulomatous disease, but otherwise no adenopathy or
Yeah.
anything else that.
There in the mediastinum, you see some OGD. Just on lung windows, it's hard to capture OGD. There's probably a little nodule there in the middle of the right lung, but not surprising to see some OGD here.
And as a sarcoid doctor, I'm sure you see a lot of like calcified granulomas in the lungs, and people are asking, what do we do with this? How do you think about that, or is there anything that you ever need to do to work those up?
Yeah, for a 50-ish-year-old guy that's got heavily calcified pulmonary nodules and some calcified mediastinopathy, statistically in this part of the country, that's more likely going to be old histo as opposed to sarcoid. I still usually will send the fungal serologies. Urine histoantigen is really only helpful if you're worried about acute infection, and the sensitivity is very low for an immunocompetent person as well, unless you have a very high burden of infection. So the histoantibody will at least tell you whether or not there's been decent exposures that they've developed an immune reaction to in the past. For active infection, we usually use 1 to 32 as the cutoff. And if you have a compatible radiographs, clinical picture, and an antibody profile greater than 1 to 32, I would usually end up treating that. Our ID colleagues who may or may not be in the room may not treat that. And then I always look for other areas of possible granulomatous disease as well, particularly in the spleen. If you have histo up in the chest, you'll typically have a few calcified nodules in the spleen as well, but doesn't really differentiate whether or not it's histo versus sarcoid, since you can have calcifications in both places.
Sure. All right. Thank you. I know you've mentioned kind of wanting a little bit more workup with the eosinophilia and then the bronchiectasis on imaging. You had mentioned room serologies. So got an ANA, an ENA, and an ANCA that were all negative.
Okay.
Having a negative ANCA, are you okay ruling out your GPA at this point?
No, so I forget what the numbers are, probably 10, 20, 30, 40, 50. James isn't nodding his head at any of these. I would say probably 10 to 20% of vasculitis can be ANCA negative and kind of evolve to positive serologies over the years. Given his history of airways disease, the mucus-filled airways and kind of central bronchiectasis, it makes you think more about ABPA or ABPM. In his case, I'll believe a negative ANCA probably, and think that this is more ABPA, ABPM type things as opposed to real vasculitis.
Sure. And there were a couple other infectious workup, cocci, cryptococcal antigen were sent, strongyloides, they were all negative.
Okay.
Sounds like less concerning just on the degree of eosinophilia anyway.
Yeah.
And then some immunologic workup was sent with an quite elevated IgE, and the IgE to the Aspergillus was positive as well.
Yeah, so really had ABPA, not just the regular ABPM. Again, from a treatment perspective, 15, 20 years ago, this patient probably would have just ended up on chronic corticosteroids and you continue to try to taper them down. In the biologic era, I think we're using these a lot earlier rather than later if they've got real reactive airways disease, especially in the context of ABPA as well, mainly to try to help minimize the corticosteroid dose and duration. I don't know if you'll mention it as well too, but from the pulmonology perspective, we tend not to use antifungals in patients like this unless there's really a concern for a concomitant infection, because typically this is just a colonization and then an allergic reaction to the Aspergillus in the airways itself.
Okay. And just based on these serologies alone, are you relatively confident in the diagnosis, or would you like pursue any other kind of diagnostic workup in a patient like this?
Is that a trick question?
I don't know.
So for us, or for me at least, I would say that that's diagnostic of ABPA. If you read the textbooks, they will also tell you that you're supposed to do the little pinprick test as well too towards Aspergillus to make sure that they react. I think seeing this in the antibody profile, we already know that they're colonized and have an ongoing allergic reaction to it. So I don't feel like the little pinprick is necessary. The eosinophilia is not to a level where I would be worried about some type of leukemia by any means, but if it's really high, 1,000, 1,500, 2,000, then I think potentially going down that pathway as well might be helpful. But at least for this patient with known airways disease that's had recent exacerbations and his COPD or airways disease wasn't that bad based on spirometry 3 years ago, I think this all fits pretty well with ABPA.
Okay. That sounds like, and the team and everybody agreed with your diagnosis of the ABPA in this gentleman, and he was treated with a prolonged steroid taper. This is a number of years ago. He was established with outpatient pulmonology and was actually able to be tapered over a number of years. He was not started on a biologic, but has been doing okay, and had a reduction in the symptoms that he was having and the number of hospitalizations. So, and just some kind of teaching points about ABPA and something I was interested to get. So this is not a patient, I feel like from everything I was reading, you really think about most in asthma and cystic fibrosis patients. And it sounds like maybe just thinking he might have an asthma COPD overlap. So just an interesting point about this gentleman who didn't fit the classic patient presentation. But Dr. Anderson walked us through a lot of these teaching points already, just that it is the Aspergillus spores in the airways causing a IgE-mediated hypersensitivity reaction that can lead to that peripheral eosinophilia and the high IgE levels. And often it's just uncontrolled symptoms of their underlying disease, wheezing and asthma, cough production, and can potentially lead to some chronic sinusitis thought to be from the fungal infection in the sinuses, or from the fungus in the sinuses. And the diagnosis, like you were saying, that the pinprick skin test is some of the board answers, and then also the serum testing with IgE levels, and then the IgG specific to the Aspergillus with some peripheral eosinophilia seen sometimes, but not in all cases. And then the classic imaging findings being the bronchiectasis, the wall thickening, and then can have some mucus impaction.
I have never ordered this once. James, our asthma guy, has also never ordered it. I think if you see the allergists, since they have all of this equipment in their clinic, they would likely do this if they saw somebody they were suspicious for. But like I would have to send them to allergy to just get that test whenever we can just do blood work instead and get the same answer.
Sure. And you kind of already walked us through the treatment, but often mostly focused on anti-inflammatory and controlling the IgE reaction. I was seeing that in some cases that the antifungals can be used if they can't be weaned off steroids or you can't control it any other way, but that is never the first line of therapy and is more of a rare treatment for these patients. So thank you for the discussion, and thank you for all the learning in this case.
Yeah, great. Thank you.
Never see